So let's start my today's gynae session. Before starting my session, few candidates exam very near. For them, my strong advice: gynae is a part of exam by which you can carry more mark. So which are the topics? Whose exam really very near? For them, my strong advice, though I will try my best to give within this time the best highlights topics to discuss for them. But for other than this, always keep eye the always common question, which are them like ectopic pregnancy question, beta HCG question. They like very much. After reducing rate, when you start, the sulfing goes to be sulfing G2, when methotrexate will continue, how you'll screen them, okay? Then molar pregnancy, and 100% I can guarantee a question from the placenta preview or abrupt show every day. So the recall, I'm always updating. Many candidates, alhamdulillah, they are passing my previous session, my previous course, they are updating me. Sometimes they forget to recall whatever the thing is that. I like gynae, though I'm not so special, but the thing is that you have to catch easily. Hormonal replacement therapy, common question, though we are not expert enough who are not working in the gynae. Progesterone only pill, combined oral contraceptive pill. In breastfeeding mom, what they will choose. Just 1 or 2 minutes I will discuss those topics for them whose exam very near, because there's some request I just got by personally, that's why I'm discussing. Though I always post PDF later my session, but today or tomorrow PDF link will be accessed by all. Try to read them or you can carry on my session. It's up to my candidates, which is not a problem. Another PDF I'll post in which all summary of the question, commonly asking question they posted. Try to look over those 23 pages, the PDF, all summary there. Another most important question everyday candidates facing is CTG. I always highlight, even if you don't know the CTG intervention, it's not a fact. Cord prolapse, variable deceleration, prolonged deceleration, there's 2 or 3 tricks you have to apply. Even if I don't know the ECG, but I have to apply the tricks. Regarding the SVT, VT, I said the PQRS, QRS complex, rate, rhythm, how we have to compare. 2:1 book, after 1 beat, 1 pause. 1 beat, 1 pause. So 2:1, that's it. Nothing to be. Need more. Don't remember. Troponin I higher, it's non-ST even, ST not higher. Regarding the CTG interpretation, like that way. Variable deceleration, delayed deceleration, bradycardia ongoing. So it's like a ECG interpretation. I will teach my every candidate like that way. On another information which hurt me today, kindly, every candidate is very special. Alhamdulillah, this session 40 plus candidates, but try to be, don't disclose any PDF, any material, any link. Don't do so. Because I am not the only one who is monitoring everything. There's a part of team also. So don't do so. If anyone mark it, it will not be good. Okay. So I'm starting my session. Today, contraception important question will be discussed. Okay. Contraception question, how they ask and what we have to remember. I always focus on that because I have to correct my exam question. So remember that way. If a patient comes to your hospital, the age is the very important, and planning of the pregnancy, planning of family, what is the ongoing presentation is very important. Every word is important. Okay. You know everything, but the thing is that why my candidates do wrong? Cause they are do very hurry. That's why. As a GP, what is your task? You have to remember it. You are not a specialist that you have to do a surgery right now. Okay, so remember this way what they are asking. So if 20 below 20-year-old female come to your hospital for contraceptive advice, we can't give Depo-Provera or medroxyprogesterone acetate. The Depo-Provera is UE generic as a, it's another as a common name that you use Depo-Provera, but mainly generic name is medroxyprogesterone acetate. In exam, they ask two way. Either they give IM Depo-Provera or medroxyprogesterone acetate. So remember, 18-year or 19-year female come to my hospital for contraceptive advice. I can't recommend them Depo-Provera or medroxyprogesterone acetate. Or intrauterine device is called Mirena. What is intrauterine device? It's a copper T-like contraceptive. So we can't do this advice. First of all, this Depo-Provera increased chance of osteoporosis. This exam question, side effect. Why we are not giving this advice for the patient? What is the side effect of the Depo-Provera? Even if you get a job in Gynae in after GPR exam, you have to know this. Okay, these are the question. Depo-Provera side effect most strongly osteoporosis. Many female who recently started Depo-Provera or Mirena. Initially, patient come to your hospital with bleeding, spot bleeding. We can reassure this patient it's a usual or it is normal or acceptable. But when I'll tell them you have to come back or follow up me when, if it is intolerable or unacceptable bleeding. So, if bleeding problematic, we have to give combined oral contraceptive pill for 3 months. Okay. Combined oral contraceptive pill for 3 months who are planning for or who are complaining of bleeding, who are planning for pregnancy, but we are not, there is no chance of giving any Depo-Provera, but we still giving for Depo-Provera which causes bleeding. We have to keep ensure that sometimes it is acceptable, but if it is problematic, we have to give combined oral contraceptive. So question wise, mefenamic acid, tranexamic, all antifibrinolytic agent for decreased bleeding tendency. We can use initially for 5 days if it is problematic, unscheduled bleeding. So non-recommended, I already discussed below 20 years. This implant, so see, if patient, two question, we can't give Depo-Provera below 20 years, but if they ask how I will maintain my contraception, we have to give this etonogestrel implants. Next plan on exam point. Next plan on etonogestrel implants. Sometimes they give, very rarely recall, but next plan on commonly they give. Also both combined oral contraceptive and progesterone only pill. It doesn't mean it's Depo-Provera injection. No. It's a progesterone only pill form. So I always say don't do hurry. So see, Depo-Provera progesterone only injection, Mirena, copper T device contraindicated below 20 years, but Nexplanon is ideal implantation and combined oral contraceptive progesterone only pill is also safe. Any patient learning difficulty or sometimes frequently forget the timetable of pill taking, we can't give combined oral contraceptive pill or progesterone only pill because that time sheet is very important. If they miss frequently, it will cause hazards for the health. Combined oral contraceptive will have many contraindications. Commonly exam question they ask frequently from thromboembolism. We can't give common oral contraceptive pill in thromboembolic patient, like a patient is silly, patient have migraine, patient have an connective tissue disorder. We can't prescribe. It's contraindicated. Learning difficulty or forget or just can't remember when she take the pill. So this peeling time is very important. Postpartum. Another important exam question: if after delivery of a female want to take contraceptive but she wish for breastfeed the child, she can't take oral contraceptive for 6 months. But if she can't breastfeed her child, she can continue combined oral contraceptive pill after 6 weeks. Two question I discussed very important. After 6 months, a breastfeeding female can continue combined oral contraceptive pill. After 6 weeks, can continue a non-breastfeeding female. Migraine is oral exam question. They can't continue combined oral contraceptive pill. Hypertension. Intrauterine device or implants. These are the long-term contraception, but a female wants you from your side that yeah, I want contraception, but I have planning for being pregnant or for being another child within 6 months. So you can't give within short period this device, Mirena, progesterone implants. So these are the wish or these are the against of his wish that you can't give this Mirena or combine or Nexplanon or intrauterine contraceptive system if patient have recent family planning. So we have to take care regarding the what she want. We have to know after how long you want to get pregnant or how long after you want to take a child. So intention planning for being pregnancy, you have to remember if it is within 6 months we can't give. So regarding delivery, breastfeeding, non-breastfeeding, I already discussed. Okay. Progesterone only pill safe in breastfeeding. Okay. This is not a oral injection form. It's a oral form because it is short term. So see, progesterone only pill have IM form, have oral form. So oral form is safe in breastfeeding women, but not IM format as a birth control methods. This clinical or medical term we already know just for discussion. Menorrhagia is heavy menstruation, metrorrhagia is irregular menstruation, dysmenorrhea is painful menstruation. But the thing is that this medical term we have to remember regarding the choose of contraception and which drug I will prescribe. This question they ask after delivery of a baby within 21 day postpartum period. No need contraception because it's a natural way as it work as contraception after postpartum till 21 day. Depo-Provera already discussed, but the question this was very important. They asked Depo-Provera injection we can prescribe. This is the DHA common question. If patient come to hospital menorrhagia and known case of sickle cell anemia, how you will manage as a contraception? You have to prescribe Depo-Provera injection. So my dear candidate, till now I discussed few highlights point. You have to look over it. What is that? First of all, Depo-Provera oral format and IM format. IM format contraindicated in below 20 years. Oral format is indicated even after 20 years or in breastfeeding female. Combined oral contraceptive always have, but sir, there is some contraindication like thromboembolism, migraine, any chance of recurrent aura, and like that way. Another form is that combined oral contraceptive pill and progesterone only pill in form. Progesterone only pill we can give commonly IM form as a contraceptive in sickle cell anemia. And after delivery of the baby, 21 days still, no need of contraception. If female want to do breastfeed, we can't give combined oral contraceptive pill till 6 months. If patient don't wish to do breastfeed, we can continue combined oral contraceptive pill after 6 weeks. So these are the highlights. After my session, I post those PDF. You must read, whose exam very near. Menorrhagia heavy menstruation exam question. Tranexamic acid. My dear candidates, this question two way. How? Menorrhagia, but definitive management or specific management. Initially, we give tranexamic acid, but definitive always combine oral contraceptive. Even they didn't give dysmenorrhea, irregular menstruation, menorrhagia, cause metrorrhagia, irregular menstruation, they could be hide, but they only give amenorrhea patient come to your hospital. How will manage definitely? Initially, we can give tranexamic acid to as antifibrinolytic agent, but definitively we have to carry combined oral contraceptive pill. So say once there is a dysmenorrhea, painful menstruation, so mefenamic acid, metrorrhagia, combined oral contraceptive pill, and menorrhagia, tranexamic acid, menorrhagia with sickle cell disease, Depo-Provera. All are exam question. A sexually active female person come to your hospital with company of menorrhagia dysmenorrhea, same as result, but intrauterine device, copper T, just remember that way, or levonorgestrel intrauterine system, whatever it is. We have to prescribe if patient complain of that she has any fibroid issue or an uterine cavity distortion. No, we can't give, cause if fibroid or uterine cavity distortion, we can't give Mirena, but if only fibroid for antifibrinolytic agent, we can give Mirena, forget it, cause it will mismatch you. Cause if you think, ma'am, there is a menorrhagia, why not initial tranexamic acid? Yes, we can prescribe tranexamic acid, but what they are asking long-term management or long-term contraception as she is sexually active. So, sexually active, long-term contraception, menorrhagia, dysmenorrhea, if any presentation comes to your hospital, long-term presentation, long-term contraception, always levonorgestrel intrauterine device. Okay. This is the contraindicated for combined oral contraceptive pill, obesity, thromboembolism. If there is uterine distortion or fibroid, so see, if there is uterine cavity distortion by fibroid, I said not distorting by uterine cavity, fibroid present but not distorted. So read the question carefully. Fibroid present, but I am giving contraceptive as implants, next plan, because uterine cavity okay, not distorted. Okay. Menorrhagia, sickle cell anemia, just remember this way, Depo-Provera injection. Emergency contraceptive within 72 hours, within 3 days. My dear candidates, just remember only one point is Livonil pill. This way they ask, within 72 hours we can carry this pill. Okay. Because this emergency contraceptive, they still not commonly asked from DHA hard exam. Just remember Livonil pill we can prescribe. So few discussion for this implant, because we already discussed few questions and my candidates are listening very carefully. I hope this discussion will be carried. nicely. So example 1 will be discussed with me. Dr. Sajma is here.
Yes, ma'am.
Example 1.
A 25-year-old female is now 22 days after delivery and wishes a contraceptive method that does not include needles. She would like to get pregnant after 6 months.
So Dr. Sajma, what are the points to favor for as a contraceptive? What you will choose for this patient after
I
delivery?
will after delivery. She
Hmm?
doesn't want to have long-term contraception, so I would
But
like to give testosterone only pills because it will not provide
which one?
longer contraception.
Which one?
Progesterone pills.
Progesterone only pill.
Yes,
POP.
yes,
Not any device, cause they want only 6 months,
yes,
right?
yes.
Thank you, Dr. Sajma. So see, first of all, this question will guide you how I'll mark my question. Is it will be IUS, they will give OCP, they'll give POP. But only one thing Dr. Sajma nicely catch that she won't get pregnant after 6 months, so she's a short period. Thank you, Dr. Sajma. Example 2 will be discussed with me. Dr. Moshumi is here. If
Yes,
Dr.
ma'am.
Moshumi is not here, yeah, Dr. Moshumi, if you want to discuss with me, you can carry with me with example 2. If you hear from first,
Yes.
loud your voice,
18
I can't
years,
hear your voice properly.
yes, I'm 18 years old with some learning difficulties, using condom and want an alternative contraceptive method. As there is learning difficulties and 18 years old, so I can give implant.
So I can think
Implant.
implant. Why not POP? Why not OCP? Cause
Because there is
she'll
learning
forget.
difficulties.
Cause she will
Yes,
forget. Okay,
yes,
excellent, nice. This is the point that my candidates nicely hearing my voice. Excellent, done. Though I'll discuss because this is actually exam scenario, that's why I'll discuss because so the SLE exam, QSP, Oman exam, every day they are asking this question. That's why I'll discuss. So Dr. Ikra,
Yes, ma'am.
question example 5 for you.
Ma'am, actually, I can't see.
Okay, if you can't see, yeah, I feel you are from the PC. I just you are from PC. That sometimes it's really difficult if I carry my session through the PC. So if you want, I can read. You can carry with me if you want. Neither I will ask another candidate.
okay, ma'am, you can read.
Okay. So your question, Dr. Ikra, a 40-year smoker, overweight female,
Okay,
come to your
ma'am.
hospital with heavy periods. So smoker, female smoker, and overweight, obesity, with heavy
Okay.
period, mean menorrhagia,
Wait, yes.
and she want to you that how she can take long-term contraception.
Ma'am,
Long-term contraception.
ma'am, for
Remember one point, long-term.
yes. So, ma'am, for long term, I can advise intrauterine device, some copper T or marina.
Why not OCP, POP?
Ma'am, because they are short term, na they
Yes, are
because
short-term. Yes, excellent. This is the way that this is the shorter for long-term Mirena or Copati or Levonorgestrel 320 device. You have to choose this way. Thank you, Dr. Ikra. Though you can't hear, see, but you tried your best. So another thing is that you can say, ma'am, contrast combined oral contraceptive I can't give because patient is obese. Patient is
obese.
overweight. We can't give. Okay. Another even in this question they ask what is the contraindicated for giving combined oral contraceptive. See, this is the overweight, obesity. Okay.
Okay, ma'am. Okay. Thank you, ma'am.
Example 4 will be discussed with me. Dr. Vizin is here, or Dr. Reza. My platform is full, but Dr. Mohammed Umer is here.
Yes, ma'am.
Yeah, Dr. Umer.
Yes, ma'am.
Example 4 discuss with me.
After initiating Depo-Provera 2 months ago, a female presents complaining of unscheduled bleeding.
How you will manage? What you will do? You are a doctor of your clinic. You already give a Depo-Provera, but complaining of unscheduled bleeding. How you will manage? What you will do?
And we will reassure the patient if the unscheduled bleeding continues, then we will give her oral
Step by step. So
contraceptive.
first initially, as a doctor, I'll
Yes,
ensure is it acceptable or not. If it is unacceptable,
yes,
initially, is it oral contraceptive or tranexamic?
ma'am. We will give tranexamethasone.
Cause in defibrillation as to decrease the bleeding.
Yes,
If it is
ma'am.
okay, it's okay, acceptable. But if it is long term, continue. So you can give combined oral
Oral
contraceptive
contraceptive.
pill.
Yes,
Okay, excellent, doctor. Yeah. Actually, this is the way we have to interpret, we have to remember. So there's a few many question my exam candidate just remember this way. It will be nice to remember because these are all our exam question. Dr. Donilda.
Yes, ma'am. Yes,
Example
ma'am.
11.
Yes. Yeah, 44-year-old female presents asking for contraception advice. She has completed her family, needs no more children, and US has incidentally revealed multiple
Multiple
small
small submucosal
submucosal
fibroid.
fibroids. She is
But she is
asymptomatic.
yeah. So see, I already discussed fibroid there, but
Hmm.
asymptomatic. So means there is no distortion present. Okay,
Okay.
but she want no need to be taking any children no more because already child only A is fact already completed family, right?
Yeah.
So how you will manage this case in your clinic, doctor? Remember 2 to 3 words. First of all, family completed,
Completed. Yeah.
fibroid present, but it is asymptomatic. Multiple fibroid there, but asymptomatic, and no need to be any child in future. So it's a long term, easy. We already I discussed this same scenario long term. If I remember, even if I don't know the scenario, I can't understand. If I say only one word, long term
Marina.
contraception, what?
Marina is the
Mirena
Marina.
or implants,
Marina
yeah, or
implant. Yeah.
implants.
Yes.
Excellent, excellent.
Yeah.
So see, Dr. Donilda,
Yeah.
short time
Yes, ma'am.
always orally form, orally
Yes.
pill, short
Yes.
time. But
Yes.
long
Yes.
term, whatever, if I can't understand the scenario, even if
Yes.
I fail in regarding what is the scenario, what is there, just remember long term means
Marina. Yeah.
intrauterine
Intrauterine.
device. Yeah,
Yes. Got
device.
it.
Yes,
Yeah.
thank you.
Thank you.
Excellent. Quickly, I discuss, though these all topics will be discussed later, there will be lots of discussion, but shortly, due to some, I will post some more question. There's lots of question I will discuss, but for some review, I want to discuss shortly for those questions. So remember, very common question from the ectopic pregnancy. My dear candidates, even you can't remember, even if you can't understand how it is important, because they must give. In my exam, my experience, I got 3 questions. from ectopic period. First of beta ECG, say sulfingostommy, sulfing, everything. So if one topic cover 3 questions of what you need, nothing. Those 3 questions will be right. This is the way, like ABG interpretation. If you correct 3 questions from one part, it is enough. So like that, it will be it's the technique for passing. So for the reason few topics, though this is a quick, but I'll discuss later. Many topics I'll 5 to 6 session from the gynecology. I'll discuss those later. So see, ectopic pregnancy, though we know very well lower abdominal pain. It could be the unilateral, it could be the bilateral. This only by this issue you can see, is it ectopic, is it torsion, is it appendicitis, only lower abdominal pain by seeing unilateral. But you have to remember other word, recent amenorrhea. Recent amenorrhea, vaginal spotting, cervical excitation. So see, why not is a torsion? Cause torsion excluded, there will be the 4-point torsion excluded, there is the amenorrhea. Torsion excluded, there is a spotting, because there is no spotting in torsion, ovarian torsion. It is not PID, it is not appendicitis, so excluded. So you can ask me, ma'am, only amenorrhea is the portion. They didn't say any point regarding the pregnancy. They say only lower abdominal pain, vaginal spotting there, cervical excitation present. So all goes towards the ectopic pregnancy. Another words, always remember the amenorrhea portion. What they say is that amenorrhea or not, patient menstruation absent 2 to 3 months or 2 to 3 weeks is okay. Or the date missed, okay. It's the ectopic pregnancy cause. Pain present, spotting there. It could be anytime unstable. We have to assess as a GP, as a clinician, what is the type of ectopic? Is it on the fallopian tube or other side of the uterine cavity? So always these are the important to look over. First of all, they ask what is the diagnosis. Another way, they ask many questions. I'll discuss later. First of all, what we have to do? We have to do vaginal ultrasound. They said TVAS, transvaginal ultrasound. Exam question. If they give this scenario, initially what you will do? So we have to see where this conception of product present. Is there in fallopian tube or any cervical area of the, or is it in the any other part of the uterine cavity which is not implanted? So we will get found it is empty uterus. So question, my dear candidates, whose exam very near for them, ectopic pregnancy management, though I'll take post those mock, it is the laparoscopy, it is the sulfingoscopy, it is the sulfingectomy. You can find out, ma'am, same topics are discussing more and more. I'll take same session more. So sulfingoscopy, jectomy, laparotomy. These are the management. So what is the gostomy? My dear candidates, gostomy means patient is stable. You just remove the product of conception which ensure the patient's fertility in future. Just product of conception you remove. That's it. It's a gostomy. Gostomy means tube is intact. There's no damage. Just you remove the product of conception. Jectomy means patient vitally unstable. It burst out. It damaged already. You have to do the cut down the tube. It's a jectomy, which decrease the fertility in future. You can't. I will post those questions. They are commonly asking those questions. Though I'll take repeatedly those questions. So jectomy goes to my SLE candidates. 2 question, recent SLE question, both laparotomy and from the gostomy. So gostomy means patient is stable, come to hospital with abdominal pain. It is not severe in nature, but it's an abdominal pain. And you've done beta ECG is high here. You saw previous first week it's a 700, now it's a 1500, it's doubling. It's not decreasing by giving my method result. You have to take the decision immediately. You have to do solving goes to me because you given method exit. These are the exam scenario for all of candidate. You started method exit. It didn't decrease, but it is increasing, doubling. We have to take decision to do goes to, because patient can do or patient can develop any time instability. If patient develop instability, unstable, BP lowering, bleeding ongoing, there is no chance of save the fallopian tube. You have to do laparotomy. Laparoscopic surgery just for the salpingostomy. This laparoscopic term is the wide term. In exam, they said this is the patient come to hospital, beta HCG high rising, but patient stable. We can do salpingostomy or laparoscopic surgery according to my question option. According to my scenario, I have to choose those correct answer. So, see, management before jumping laparoscopy, before studying laparoscopy, if patient is stable, we will do or we will keep follow up always weekly beta HCG. If more than 1400, we have to do laparoscopic surgery. If it is below 1400, we have to observe and repeat vaginal ultrasound later. My dear, is still these topics will be discussed more later. Just I am highlighting 4 points. Remember, more than 1400 salpingostomy. Laparoscopic surgery, I say it's a wide term. It's a not specific term. So they will say it's a 1500. What you will do? Exam question. We have to do salpingostomy. My ACD candidate. It's a below 1400. I'm giving method result. So next week I'll keep on follow up. I'll see the the gestational sac. It is decreasing or whatever the beta HCG. If it is decreasing, it's enough. I will continue the method result. But if it is not decreasing, we have to take decision immediately. Laparotomy always in case of instability. Okay, these topics never should wrong in the exam because you must get 1 or 2 questions. A pregnant with history of cesarean section develop profuse vaginal bleeding. See, this is the recent exam question. Recent cesarean section and now come to your hospital with profuse vaginal bleeding. Another question, just remember. Always see, is it in emergency or clinic? Because this background they'll give. If it is clinic, so we have to remember those way. But you are emergency doctor, so how I can do definitive management? It's not possible in emergency. We have to take care. We have to shift in a specialized team. We have to take care according to the management. So I saw today mock. I actually was checking the question 6. A maximum candidates mark 6C, catheterization. As an emergency, can you do this catheterization? Is it possible? It's a basic because you have to think your job situation according to scenario, because this is your duty to do to solve this problem. That's why this is the exam. Forget the license. So say uterine rupture question, patient severe abdominal pain, shock, tachycardia, history of cesarean section recently or whatever they said within 1 month or 7 day back or 14 day back. So this vaginal bleeding proof is how it could be. What even if you think recent cesarean section, recent surgery, profuse vaginal bleeding is a rupture. If you ask ma'am why not torsion, why not ectopic, is it possible after cesarean section? Because they'll confuse you. Rupture ectopic pregnancy. So you think okay after cesarean section patient develop instability, hypertension, tachycardia. So it's a rupture ectopic. How dear? After cesarean section, profuse vaginal bleeding, is it possible for, because this question already some candidates missed. So remember, after cesarean section or any surgery, if patient develop anesthesia, either this surgical site become teared out again, or patient develop instability, or if after seizure it develop patient uterine rupture. In the last weeks of pregnancy, so in late week of pregnancy, painless vaginal bleeding, actually this question I'm discussing, though there's many topics, whose is a very near. Remember, always my manomis is PP. PP means what? Previa painless. PP. Previa always painless. Another word, AP. In your exam, you will got many confused. So remember those mnemonic. AP means what? Abruptio painful. Or you can notice shortly. Abruptio painful, previa painless. That's it. So this is 70 to 80% chance to get a question from this topic. So if PP, painless bleeding, we can do TVAS. But patient pregnant, painful vaginal bleeding, common question in exam. We have to do CTG to check fetal condition. Is it patient fetal distress or the whatever the fetus condition? Always abruptio placenta, painful vaginal bleeding. We can't do TVAS. TVAS is contraindicated. Transvaginal ultrasound. We have to see the CTG by seeing fetal condition first, because this is the paid exam question, my dear candidates. Pregnant lady, third trimester, present to your hospital. So third trimester, tachycardia, fever, history of prom, very important. Today I'm discussing few highlights, not deep. All will be discussed deeply later. History of fever, tachycardia, prom present means sometimes 36 or 35 years we patient or female patient can develop prom. It's not so severe to deliver the baby, but small prom we can give the antibiotic to heal the prom, premature rupture of membrane to decrease the fetal distress to maturity of the lung. But this prom is not good for the patient cause it causes chronic cervicitis. So third trimester patient tachycardia, fever, history of prom, vaginal discharge. Suspected chorioamnitis, exam question. Why? Chorioamnitis cause this tachycardia and fever. Chorioamnitis. Only one strong clue here there is prom history. Yesterday my candidates passed and telling ma'am, I feel 140 question is from your lecture, just 10 question I was confused. This is due to only practice. So I always say do practice with me. I am posting every day mock. This mock enough for building confidence. Even if you do wrong, it's accepted because you wrong this place will correct your exam. So when my candidates give feedback, every question just like from your session, your practice, it's enough. Whatever the MOH and ACT candidates every day. So first listen my session carefully and do practice accordingly. So this from chorioamnitis exam question, same scenario. See, I said first chorioamnitis, history of prom, third trimester. But for PID, you can say abdominal pain, fever, deep dyspareunia, dysuria exam question, menstrual irregularity. So in PID question, there is a last question I'll discuss later. Chapter wise, topic wise, I'll discuss later. Just for my few candidates exam so near, that's why. Fever, dyspareunia, lower back pain, vaginal discharge, cervical excitation. It's a no possible of having any cervicitis or amnionitis. First of all, amnionitis is excluded cause patient is not pregnant. Cervicitis is excluded cause it's a long time lower abdominal pain. Cervicitis, menstrual irregularities never occur. Pelvic inflammatory disease is or pelvic inflammatory disease always cause menstrual irregularities. Atrophic vaginitis. This exam question they ask how you will manage treatment. Atrophic vaginitis, we have to give topical estrogen. Even they ask there is a sexual problem, there's atrophic vaginitis develop, how you will manage. So see, dyspareunia, dysuria frequency more is age more than 51. So whatever the age they ask atrophic vaginitis, though it is after postmenopausal women, but remember topical estrogen exam question. Dyspareunia, dysuria frequency, hot flashes, night sweats, postmenopausal syndrome, hormonal replacement therapy we have to give. So hormonal replacement therapy, this question, my dear recent candidate, asked two way. If you are a physician, patient come to your hospital, ma'am, I am feeling hot flash, I am feeling night sweats, give me hormonal replacement therapy, give me pill, I listen, I do study, this pill will be very helpful, I will not be agitated, I will not face this night sweats. No. You have to do refuse. A patient if demand any medicine from herself, as a physician you have to do analyze, is it true or wrong, because you can't give any medication first of all if it is not chronic case, like every weekly follow-up patient complaining, same okay, you can give this medication, but first of all or patient come and patient wish to get this medication, no. As a physician you have to do analysis, is it acceptable symptoms or you can give hormonal replacement therapy. Because why you have to do analysis, because this hormonal replacement therapy has many side effects, you have to counsel them. I can give you, but it can cause osteoporosis, can increase risk of thromboembolism, you can face this is high risk, will you wish to get this? First of all you have to, this exam direct question, if a patient comes to your hospital wishing for having hormonal replacement therapy, but patient only have night sweats or hot flash only, will you accept her wish or not? So we can't accept her wish. Same way, it's a common presentation regarding the cervical atrophy, just shortly. Painless vaginal bleeding with placenta in high, just shortly remember any placental high in position, not placenta previa, not placenta abrupti. Just remember placenta in is higher position, means it's above the position, so along with painless bleeding, it's not previa. Just one point, placenta is higher. Just I'll discuss those topics when it will be the umbilicus, when it will be the symphysis brevis, when it will be above the umbilicus. But in ectropion, painless bleeding, but it's above the gestation, so it will be the ectropion. Okay, secondary chemotherapy. After chemotherapy, develop secondary amenorrhea. It's the premature ovarian failure. Any female more than 51. So another question common, if age more than 51, postmenopausal bleeding. Postmenopausal bleeding. It's just mark blindly. If I'm giving advice, just postmenopausal bleeding. Always more chance of having endometrial carcinoma. Just a few minutes ago, one candidate asking me why not it's a bile duct injury, why it's a stone. Stone causes obstruction. That's the patient develop patient bowels not passing. Patient bowels not passing, develop jaundice. It's a basic. Even if injury, it will be healed. There's no obstruction. How it will be the jaundice? So same way, endometrial carcinoma question commonly after postmenopausal, developing commonly postmenopausal bleeding. So you have to mark according to the common presentation of common finding. If thick, we have to do the hysteroscopic biopsy. Exam question, endometrial thickness higher. For definitive diagnosis, the endometrial thickness higher, we have to do hysteroscopy and biopsy. Another question they asked from the ectopic vaginitis, I discussed that we have to give topical estrogen, but vulvovaginal atrophy, ectopic vagina is always postmenopausal patient and postmenopausal bleeding. So we have to make sure we have to do this ultrasound plus minus hysteroscopy. Because why? If ectopic vaginitis, this scenario, they give this ectopic vaginitis. They didn't ask how we'll manage. If they ask how we'll manage, we can give estrogen, but how we'll investigate or further more investigation, we can do initial ultrasound and later hysteroscopy to see the endometrial or check the endometrial carcinoma evidence. Next step, always transvaginal ultrasound that to rule out the endometrial carcinoma. So first ultrasound, then hysteroscopy, bioscopy to see the carcinoma present or not. I'm highlighting few topics, so no need to be take anyway. I'm telling same words samely because many of I am not understanding. All topics to be discussed later. You can just exam very near. That's why I'm discussing. So endometriosis question is a 5-star, or you can say 4-star. It's a very important topics. Endometriosis question, adenomyosis question. In Allah note recall the given. Just remember one point. Adenomyosis question, I will mark when if there is a history of any time myomectomy or any surgery before uterine surgery. It is cause a high risk of having or frequent DNC. If you think, ma'am, there is a chronic pelvic dyspareunia, why not endometriosis? No, only one word. As per remember, I discussed in on my own recall question. Only one word. Frequent DNC. Having myomectomy before or 2-time myomectomy before. That's it. It's adenomyosis. For endometriosis, it could be the even simple young patient or childbearing patient, reproductive, just still on reproduction age. So important clue is bleeding, dysmenorrhea, dysuria, triad. 3 triad. What are that? Triad is dysmenorrhea, dyspareunia, and dysuria. 3D. We have to give initially NSAIDs to decrease pain, but for the bleeding, oral contraceptive pill. Tubo-ovarian abscess, tubo-ovarian ovarian torsion. This topics. Paid question, just one word, fever. If fever not present, it's a torsion. If fever present, it's abscess. Because Pain present, abdominal pain present, tenderness present, no discharge, additional hinge, sexually active, whatever it is. But remember, abdominal pain with tenderness, if no fever, it's a torsion. If fever, it's a abscess. We have to do the ultrasound first to see, is it torsion? As far I remember, in my general group, maybe one candidate asking regarding the ethics question, you can't, actually my strong advice, you can't make your rules. Ethics is the point in which they said this way you have to proceed. Like that, what they only said it's over and torsion, but they didn't say patient unstable, you can't do surgery. They said okay, it's a torsion, but patient refused for taking any surgical procedure. But if any candidate says no, I have to take the decision from the husband, I have to take the decision from the committee. No, I have to understand the question scenario, what they said. They said it's a diagnosis. We offered her for the surgery and she refused. Okay, it's a khalas. We offered surgery, but she refused. If it's emergency, vitally unstable, there is ethical committee, there is another way we have to take ensure it, because it's a unstable life-threatening situation. Patient can't take the decision immediately because patient is not mentally stable. It's the point. It's easy. Ethics is easy. Mentally stable, patient giving decision is acceptable. Patient mentally not unsettled because it's an ongoing shock. We can't take decision and we can't take the wish from my patient. What she given. So always remember the scenario, what they said. Ovarian torsion is emergency surgical, but they didn't say the patient is severe abdominal pain, patient is unstable, immediately patient is telling that patient is not accepted to the surgery. Okay, there is an ethical committee, we can take decision from there, so it's accepted. So this way we have to take we have to need decision. Deep ovarian abscess already discussed. Ovarian tube see there is a mobile mass, there is unilateral iliac fossa pain, nausea, vomiting. We have to refer the patient in gynecologist as the midway surgical emergency, sudden severe. So sudden severe is the surgical emergency and already vomiting started. Okay. African patient bloating, heavy regular period, enlarged uterus. Enlarged uterus question, either it could be the molar or fibroid. My dear candidates, always read the question first. Is it fibroid or molar? Molar will be the what? Amenorrhea history. So fibroid cause there is a heavy regular period. This enlarged uterus, they will misguide you by, they will give the option molar. You can't do select it. Inability to conceive, obesity, LH high. It's a polycystic ovarian. It's a, I can't say it's a high yield important question for them. The PCOS question, LH high, acne, obesity, acanthosis nigricans, androgen high, menstrual irregularity. Either they'll ask what is the diagnosis, or they'll ask what is the investigation you will do. I will do initially pelvic ultrasound for the hormonal space. We will do LH, which will be the higher for the polycystic ovarian syndrome. My dear candidates, don't be miss it because PCOS question, paid question for the exam. Pelvic condition syndrome is not so important, just shortly. If patient chronic pelvic pain worsens by standing, worsens per menstrually, coital act, it's a condition syndrome. No, it's not so important, just remember. This is the high yield, it's a triple stress or 4 stress, it's a visceral immunoglobulin. My MOH, every candidate. Immunization details I will discuss again more, best shortly. Higher topic is that Varicella zoster immunoglobulin. Varicella zoster immunoglobulin exam paid question. Immunocompromised patient means patient either taking the steroid or using inhaler or ACLI or anyway patient immunocompromised. Patient exposed. We have to give immunoglobulin. C. Patient pregnant with exposed. After pregnancy exposure, before immunoglobulin, we have to check antibody status. Because patients before already taken this vaccination, so there will be the antibodies. So if antibody positive, no need to take immunoglobulin. We can keep isolate from the exposure. That's it. And to follow up if any symptoms develop, we can give antiviral. My dear parents, listen carefully. In pregnancy, before giving immunoglobulin, we have to check antibody status. If it is negative, we can give immunoglobulin. If it is positive, we have to keep follow up. It's exam question. Because if patient develops symptoms, we have to keep isolated from exposure. If develop, then we have to give antiviral, not immunoglobulin. Immunoglobulin, antiviral, both. If patient symptomatically upset. So read the question first. Both very important. If she was exposed to a chickenpox long time, more than 2 days, still rash didn't appear. So see, patient even don't know the patient exposed, but right, anytime patient remember that yes, 2 days ago there is a chickenpox patient I was exposed, but no rash developed. Actually, things that patient pregnancy and immunocompromised, because we have to keep concentration this group of people. If patient healthy, 2 days already gone, no rash develop, we can only say it's okay, we can carry on, or we can do reassurance. Newborn with peripartum exposure. Newborn baby chickenpox exposure, we have to give immunoglobulin. So these three group we have to ensure if exposure, varicella zoster immunoglobulin. When oral acyclovir, if patient immunocompromised, develop pox, immunoglobulin plus antiviral. If pregnant, develop pox, immunoglobulin plus antiviral. Exam question, paid question. So I will discuss few questions, though my candidates know very well, but this discussion will make sure that they are understanding everything. So from this platform, I will discuss from Dr. Kutsia.
Yes, ma'am.
Example 1.
A pregnant in second trimester was in significant contact with a child with chicken pox 7 days ago. She has never had varicella zoster infection. A stored blood sample is tested negative for varicella zoster virus IgG. Now she has no rash. So for pregnant in second trimester, we can't give varicella vaccine. As she is pregnant and varicella vaccine is contraindicated in pregnancy, and plus she doesn't have, she didn't develop any rash, so there is no need to go for a varicella vaccine.
Is it so that Dr. Kutsia, see, 7 day back, patient developed or patient exposed significant contact, and she never have infection before. So see, and I discussed Dr. Kutsia, we have to do antibody status, and the antibody status is what? Negative.
Negative. But ma'am, she still don't have any rashes.
But patient is
So-
on the group of immunocompromised.
We can give immunoglobulin.
We can give immunoglobulin. We can.
Yeah.
You have to ensure. You have to give immunoglobulin because the immunoglobulin status negative. Negative means she has no antibody.
No antibody. Okay.
Even she didn't. I said you. I will discuss later after example 2. Okay, Dr. Kuse with me. Example 2 will be discussed with me, Dr. Hira. If Dr. Hira is here or not?
Yes, ma'am.
Read.
Example 2.
Yeah, example is that someone exposed 8 days ago. Okay, 8 days ago. What I mean is a patient exposed 8 days ago. Okay.
Yes,
8
ma'am.
days past. 8 days past, he developed chicken pox.
Yes, ma'am. Ma'am, we will give antiviral acyclovir.
First of all, he developed chicken pox. This question reassurance will not be there cause they ask another way, does he, if the infective period of chicken pox 2 days before the appearance of the rash. So 8 days have passed and he developed, 8 days already passed, 8 days passed.
Yes,
incubation period 2 days.
Okay.
It's important. Incubation period, so 8 days passed, then developed rash. It's not infective. It's a, this rash is not harmful, it's not infectious. So after 48 hours or after 3 days, even we can actually we wait till 72 hours. So 8 days after if this pox develop, it is not harmful, or we have to no need to be worried regarding the antiviral. But yes, this rash, if it is, they say that it is a very symptomatic patient develop rash, which is patient is condition is a very worsening. Later, we have to take the decision regarding the antiviral. So, Dr. Hira, this question they ask 8 days past then develop rash. So, 8 days past develop rash is a non-infective rash. Non-infective rash. It's a we can keep reassurance, we can keep follow-up. But this infective rash, if patient condition is worsening, we can. So, their time schedule is very important. We will take importantly for varicella zoster till 72 hours or 3 days.
Okay, ma'am.
Okay.
Okay,
So
ma'am.
when 8 days pass and now develops, it could be non-infectious type.
Okay, ma'am. Okay, ma'am.
Okay.
Okay. Thank you.
Another Dr. Kusia was Dr. Kusia. So see, my criteria for the immunoglobulin, even that if your pregnant patient didn't develop any rash, you have and we have to check the antibody negative. So we have to give immunoglobulin.
Yes.
Okay. Even
Yes,
if it is newborn, exam question, paid question, newborn baby exposed to the rash. How from where this newborn baby got antibody? It's a newborn, so we have to give. We have to give immunoglobulin. Okay. This acyclovir question already discussed with Dr. Hira that patient they already passed 8 days. I am a patient. I exposed within 8 days, but 8 days passed and I developed now box. First of all, we have to keep follow up. Reassurance first. Because why? This reassurance initially caused 8 days already passed, now developed pause. If it is not acceptable, this rash. Symptoms worsening. Later acyclovir. Second step acyclovir. First step acyclovir immunoglobulin in case of patient immunocompromised, pregnant, newborn baby. These are the category we have to take care for them because these are the vitally important. But patient healthy, like Dr. Hira I discussed, patient healthy, 8 days pass, now develop rash, we can keep follow up. We can do reassurance. We can take, yes, if it is unacceptable rash, if it is unacceptable presentation, we can give antiviral. This is the twisting question, very important question by every candidates. Few question from the PPS they ask My exam question from the secondary PPH and how they manage the causology. I forget those questions. Just remember the PPH question. 40 very important causes. Postpartum hemorrhage. 40 uterine atony very important. The cause trauma, coagulopathy, tissue. So uterine atony, laceration, coagulopathy, retained product of conception. So these are the 4 types. First of all, we are doctor. We have to know, even they give many job vacancy regarding the gynae session. So who want to practice in the gynae, we have to know the scenario. Though many candidates, mashallah, very well done. So remember, atony is very common for having PPS, but primary PPS, secondary PPS. Primary PPS, when I tell the primary PPS, within which time, is it 24 or 48? Anyone know the primary PPS duration? Is it 24 or 48?
24.
Hemorrhage
24.
occurring within 24 hours.
Within
24,
24 hours.
Yes.
it is
24
primary. After 24 hours, it is
Secondary.
secondary. Yeah. So example 1 will be discussed with me, Dr. Pallavi or Dr. Tamanna.
Yes, ma'am.
Yeah, it's a Pallavi maybe.
Yes, ma'am.
Okay, example 1.
Prolonged labor plus uterus is still palpable above the umbilicus after delivery, the postpartum hemorrhage. Above the umbilicus, uterus palpable. Postpartum hemorrhage.
My dear candidates, see what they said, prolonged labor. So it's a prolonged.
Yes,
okay.
ma'am.
Then uterus is still palpable above umbilicus, because after delivery of the baby, it will the shorten down.
Yes,
it's the atonic uterus. Excellent. It's the atonic uterus. So we have to do first, initially they'll ask the management, we have to start the uterine massage, then oxytocin. Example 2 will be discussed with me, Dr. Fatima.
Yes, ma'am.
Okay, example 2. Start. I'll finish.
The primiparous diabetic Asian lady. Can I read, ma'am?
Yeah, start.
Okay. A primiparous diabetic Asian lady has just delivered a 4.5 kg baby. The delivery was done by the aid of forceps. The placenta was removed with
continuous contraction. Okay. Continuous contraction. The placenta was removed and her uterus is still contracted.
Okay.
However, she continue bleed excessively.
Okay.
What is the cause for PPH here? So, my dear candidates, first of all, from your part, tell me your risk factor.
The trauma is the cause.
Trauma is the cause. Excellent. Because why? Patient's baby is
4.5 kg baby. Overweight. 4.5.
Overweight. And still continuous contraction.
Yeah.
Right?
Then. Yeah.
So it's a contraction ongoing and it's still continuous bleeding excessively due to the
trauma.
Cervical trauma. Most common PPS cause is the uterine atony. Then uterus is well contracted and diabetic mother. You see your case, diabetic mother, macrosomia baby due to the PPS of the trauma of the delivery. Okay.
Okay.
Example 3, another Fatima. It's a Fatima Peri.
Yes, ma'am.
Example 3 for you.
Ma'am, prolonged labor plus uterus is felt boggy and relaxed above the umbilicus after delivery with PPH.
How you will manage? So say prolonged labor, felt boggy, relaxed above the umbilicus. So it's a, what is the diagnosis?
Ma'am, it's uterine atony.
Okay, so how will manage? I already discussed with Dr. Pallavi. How will manage
Uh,
uterine atony? What you will do initially? I just now I discussed with Dr. Pallavi maybe. Uterine atony will give first
uterine massage.
massage, then
oxytocin.
oxytocin.
okay.
Yeah. Okay, this way we have to remember. Ectopic pregnancy shortly again regarding this lower abdominal pain, tenderness, first symptoms. These are the and this ectopic pregnancy case, the missed period will be there. There will be the vaginal bleeding. There will be the peritoneal bleeding. There will be the cervical motion, tenderness, cervical excitation. Pregnancy test will be positive. We have to do a transvaginal ultrasound. If it is empty uterus, so it's the we have to manage according to stability and instability. It's the beta HCG value already I discussed. Instability case salping jectomy if goes to me regarding the stability case. So key 7, question 7 will be discussed with me, Dr. Kishori is here.
Yeah, ma'am, I'm here.
Key 7. Is it able to read the question 7?
Yes, ma'am.
Okay.
Okay.
Seven.
A pregnant female in the 38th gestation with history of cesarean section develops profuse vaginal bleeding with severe abdominal pain, with plus going into shock, that hypertension and tachycardia. CTG shows distressed fetus, reduced variability and late respiration.
So what is the cause or what is the diagnosis? Dr. Kishori, you will explain me in point of the diagnosis why you are thinking. Okay? What is the diagnosis?
I think she's multiparous because already there is a history of cesarean section. And recently she is 38th week of gestation and she's having profuse vaginal bleeding plus severe abdominal pain and the patient is in shock.
So what is the diagnosis?
Ma'am, is this a case of because she's in 38 weeks and having a vaginal bleeding plus hypertension and tachycardia? Is it antepartum hemorrhage?
Okay. But I just discussed just few minutes back, Dr. Kishori. Easy question, exam question, cesarean section history, patient pregnant, profuse bleeding, shock. If you say I am your patient, I have a surgery 2 months back. Now proof I am going to the hypertension. What could be the answer due to the hypertension? From where it is bleeding ongoing for developing hypertension? Due to the my rupture side or my cesarean side or it's a rupture uterus. Okay.
Yes,
if you remember this antepartum postpartum, no need to be think because clean cut exam scenario, it's a rupture uterus. Dr. Kishori, okay?
Okay, ma'am.
If you tell me, ma'am, it's antepartum, it will not be remarked because antepartum hemorrhage patient will not develop shocking condition. This profuse bleeding, patient develops shock due to this bleeding of rupture uterus. Okay. So now how will manage? What is the definitive manage? What you will do for this rupture uterus?
We go for CS, ma'am, because she's already the
patient unstable. We have to do laparotomy.
Laparotomy.
We have to do this as a patient. Always remember another important point. Whatever the thing, patient unstable. Patient unstable, we have to do open the case. We have to do laparotomy. Instability. We can't do anything. Okay? It's a clean cut. Urgent laparotomy we have to do cause patient on shock. So treatment of uterine rupture. So see, first of all, you say, Dr. Shuri, previous Caesar, uterine surgery, then so it's the risk factor for uterine rupture, excessive oxytocin. Another clue, ongoing oxytocin, patient on labor. Another exam question, patient on labor, ongoing oxytocin, sudden develop profuse bleeding with shock. My dear candidate, it's the diagnosis of rupture uterus. Okay, it's the another diagnosis. So excessive oxytocin cause uterinic agent contraction more causing rupture. Okay, another is obstructed labor. So two exam questions. First of previous years, another is excessive oxytocin. Two way they ask. Just remember, excessive oxytocin, ongoing prolonged labor, sudden severe bleeding from where? Still baby didn't pass. Sudden, even in our internship, when I will deal more than 100 cases every day, because there is it's away from our center side, so we have to deal this kind of case. So these are the way that they don't know how to manage. So this ongoing oxytocin, uterine contraction ongoing, and it goes rupture. So it's the urgent laparotomy. Placenta previa painless, placenta abruptly painful, I already discussed, and always rupture is painful. Another important I already discussed the abruptio placenta question. Always I have to check fetal distress by doing CTG. Exam question, what you will do? Patient 38 weeks, abdominal pain ongoing, vaginal bleeding ongoing, third trimester, patient fetal on distress. What will do? We have to do cardiotropography, CTG, not ultrasound. Patient fetal distress, we have to do urgent cesarean section. If patient is not fetal distress, if it is normal, we can do vaginal ultrasound to check the previa and abruptio. If CTG not option is another recall, we have to choose this ultrasound. So this is the highlights one for the exam, placenta abruptio and previa. So see the presentation, kindly mute the mic to enter the session. So placenta abruptio, so see and previa. Abruptio always abdominal pain, tenderness, and ultrasound miss the early abruptio. So first of all, in third trimester, we have to do CTG. Previa painless bleeding, we have to check by ultrasound. So another very important question regarding the hormonal replacement therapy, postmenopausal symptoms, hot flashes, night sweats, irritability, vaginal dryness, dyspareunia. If there is uterus, not hysterectomy done, we can give hormonal replacement therapy. They will give no history, but if hysterectomy done, another possible answer that regarding that after hormonal replacement therapy, what choose we will choose? We choose progesterone patches or transdermal estradiol to decrease the postmenopausal presentation. If no uterus or history of the hysterectomy, estrogen only pill. So remember, my dear candidate, if hysterectomy or intrauterine device in the place, we have to do estrogen only. We have to give only estrogen. If uterus present, we have to give progesterone only patches or estradiol. This question already I discussed. Example 1 will be discussed with me, Dr. It's Priscilla or Priya. Anyone? Priscilla or
Yes,
Priya?
Priscilla. Yes.
Okay.
Priscilla.
Yeah.
A female at her 39 weeks gestation had passed clear viscous fluid for vagina 4 days ago. Now she's feverish, sweaty, and with suprapubic tenderness. The symphysis fundal height is 35 cm. There is fetal tachycardia of 175. WBC and CRP are high.
Thank you for that.
What is the diagnosis? First of all, Dr. Priscilla, you will tell me that What are the points for in favor of your diagnosis?
Okay, I'm thinking of chorioamnionitis because she already passed viscous fluid, so PROM, and then feverish, what WBC and CRP high.
Excellent, excellent. All goes towards the chorioamnionitis. Okay, and you didn't confuse by see the gestation, pulse, clear, viscous fluid, and you already catch nicely. It's a probe. This is the point they didn't nicely give this a probe or not. Who are expert enough? Nicely, Dr. Priscilla saying it's a probe. Nice, excellent. Okay. Thank you. Chorioamnionitis, so see shortly, is inflammation of the fetal amnion and chorion membrane, typically due to ascending bacterial vaginal infection when there is a rupture of membrane. Prom is a major risk factor for chorioamnionitis. Ascending bacterial infection of the vagina, fever, sweaty, high WBC, high CRP, there is inflammation, and there is a supervivious, it's a fetal heart rate small of the dead, especially it's a gestational age will be the small over the dead, as there is a prom is ongoing, there's a chorioamnionitis, there's oligohydramnios, so we get in the pubic symphysis according to the gestational age, okay, it will be the lower down. Chorioamnionitis picture will be there is a maternal tachycardia, fetal tachycardia, so these are the presentation, uterine contraction, suprapubic tenderness, very important history of the prom. So amniotic fluid could be the purulent, offensive, foul smelling due to the infection. Okay, these are the prom. So tachycardia, ESR, CRP high, fetal tachycardia, maternal tachycardia, these are the prom, and this is the question for the chorioamnionitis. So symphysis fundal height, this is the normal. Symphysis fundal height in case of prom or chorioamnionitis, it will be the lower, but in 12 week, this is paid exam question, my DHA candidates. 12 week it will be on the pubic symphysis, 20 week it will be on the umbilicus, in 20 to 36 week it will be on the according to the gestation. Like if it is 36 week, it will be the 36 plus 2 or minus 2. If it is 20 weeks, so 20 plus minus 2. So according to the gestation, plus 2 or minus 2 acceptable. 36 to 40, it will be the according to the Gifford process. So strongly pressure exam question till umbilicus 20 weeks. This is the paid and frequent exam question. 20 week umbilicus is actually my recall. So these are the way we have to remember 36, 40, 22, 36, we have to calculate this way. Large rate of uterus is the last topic for today. Large rate of uterus, we have to remember this polyhydramnios, hereditary mole, these are the exam question, large rate of the uterus, tumor, and this is twins, these are the cause, and for the smaller, oligohydramnios and IGO, remember, that's it. So shortly, I want to discuss this key 11. Key 11 will be discussed with me, Dr. Hira.
Yes, ma'am. A pregnant lady at 37 weeks gestation, present with lower abdominal pain, plus small amount of vaginal bleeding. Placenta previa, ma'am.
Placenta previa, but lower abdominal pain
and small amount of vaginal bleeding.
So it's a abruptio or previa. It's a pain. So it's a pain and bleeding.
Ma'am, it's abruption, placental abruption with pain.
Yeah.
Previous painless.
So, yeah. So how will manage? Next, what you will do?
Placental abruption.
Placenta previa, my dear Dr. Hiran, I am frequently telling one word that for previa, what I will do? For abruptio, what I will do? Patient pregnant, 37 week. Now, previa. Will you do ultrasound or CTG?
Ma'am, for abruption, we do CTG.
So it is what?
It's placental abruption for which we will do CTG.
So see, Dr. Hira, your question. First step CTG is a suspected abruptio. If no pain, so ultrasound.
Yes, ma'am.
In exam, unfortunately, if you didn't see any CTG option, mark ultrasound. But if it is CTG option, mark CTG because abdominal pain they said. So it's abruptio or preview, we don't know. But if 37 pain present, do CTG for to see the fetal distress, fetal position, fetal condition. Okay. Don't forget the pain part. Pain is very important.
Yes, ma'am.
Okay.
Thank you.
Okay. Welcome. So key 12 will be discussed with me. Still, Dr. Badhan is here. Dr. Monirujjaman. Jubair. Priya, Doctor.
I'm Dr. Priya here, ma'am.
Yeah. Your question from the this way that a patient 25-year-old come to your hospital with to use this Mirena. So 25, special 25, okay. And develop lower abdominal pain and irregular menstrual cycle. So 25-year-old female come to hospital using Mirena, develop lower abdominal pain, irregular menstruation. I already discussed this point. So what is your diagnosis?
PID, ma'am.
PID. Why? Cause?
And because of lower abdominal pain, and her age is less than 25, and she's having irregular menstrual cycle, and she's using intrauterine device also. There's some infections come over there.
That's why. Yeah, excellent, Dr. Priya. Excellent.
Thank you, ma'am.
Okay, so today I'm ending my session, hoping all will participate soon. Today or tomorrow morning the mock question will be posted. Try to confidential the materials PDF. It's my strong recommendation for my all candidates. All my candidates actually I like very much from my heart. Always prayer for them, my duas from them. Try to keep on confidential. Okay, so thank you everyone. Assalamu alaikum to all.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.